muted.
Want to have the MRI guided biopsy?
So they need to know if it's available, number one. And it's typically used in men who have had a prior negative biopsy, but there's some concern that there is a tumor that has not been visualized. And so that is an indication for getting an MRI. And then on the MRI, if lesions are seen and they have the capability, then they can perform an MRI ultrasound fusion biopsy. And so the terminology that you would use is called fusion biopsy. And certain centers have that. We have it at Vanderbilt. Big cancer centers like Memorial Sloan Kettering, Fox Chase, and even some large private groups have invested in that. But it's again not an inexpensive platform, but it's a way of having a more specific targeted biopsy of any suspicious areas.
Got it. I think that's really helpful for people to understand exactly what to ask for.
Mm-hmm.
We have a question. Actually, this didn't go into the presentation, but one of the tests that people have is the Foundation 1 test, the one from Foundation Medicine. And how is that used in genomic testing? Is that a test that's used in men with localized disease, or is it only really for men who have more advanced disease? And sort of how does that full genomic sequencing differ from some of the specific tests you talked about with the shorter sequences?
Yeah, so any of the genomic testing, including the one you just mentioned, you're basically looking at changes in specific genes that have been associated with aggressive prostate or aggressive cancer. And if you do whole genome sequencing, you're likely to find a lot of alterations that might not necessarily be associated with prostate cancer. And so that's why, the test that we showed here, 17, 22, 40 different genes, you can find probably 1,000 different genes, but you want to, the ones that we've talked about have been specifically shown to be independent markers of aggressive disease. If you do whole genome, you will likely find a whole lot of abnormalities, but they might not necessarily be related to prostate cancer. And you're definitely you're talking about a much more expensive test.
Right. So would the Foundation 1 test be something that probably somebody with localized disease had, or was it more recommended for men with advanced disease?
I think it's localized disease.
Okay. Great. And then we have a practical question about in terms of like biopsy slides. How long are they? If somebody has a biopsy, how old can a slide be to be used for one of the genomic tests, or would man need a newer test?
No, you can use it at any time. So the biopsy tissue is placed in what's called fixative, and then placed on the slide and then covered with a glass slip. So it's actually, you can use those probably indefinitely, because once it's fixed, you don't have tissue breakdown. So in one of these studies, actually for Oncotype, I participated in the trial where they were looking at tissue in African American men, and we were pulling slides from 10 years before. So it can be almost any time. They don't need fresh tissue for that.
Okay, so even up to 10 years old, that's awesome. That's wonderful news for people to be able to know that they don't have to go back and have another biopsy.
Yeah.
So somebody asked, how accurate is the Oncotype test? And sort of a nebulous question, but I guess sort of the best way you could answer that. I guess how confident would you be in sharing the results with a patient?
You kind of faded out on me for a second, so I actually didn't hear the question.
Oh, sorry. It's a challenge I have these days. The question is, how accurate is the Oncotype test? And so, you know, how confident are you in using that with your patients and the results from that?
So it gives you, it's a spectrum, so the higher the number, the greater the chance for aggressive disease. And so there's no cutoff, okay, per se, as far as, you know, above this number, aggressive, below this number, not. It's on a spectrum. So the higher that number is, the more likely you are to proceed with aggressive treatment. So unfortunately, there is a little bit of a gray zone because sometimes things are just, you know, intermediate. But you know, the worse the score is, the more likely you are to choose aggressive therapy.
Great. And so we actually have a question from somebody who has decided to go forward with surgery, and he'd like to know, I don't have more context, but he'd like to know if it would be best to do genomic testing from the surgery sample or from the biopsy sample. And I don't know if, I don't have any information about the actual characteristics of his disease, but, you know, sort of with that information.
Yeah, you know, if they do it from the whole prostate gland, there's basically more tissue involved. Theoretically, it doesn't matter because the genomic alterations can be seen either in the tumor itself or in tissue around the tumor, what's called the halo effect. But if you have the whole gland, they can actually isolate the whole tumor, and they can even send off areas where there may be more aggressive features. And so it's probably best if it's done on the final specimen, on the prostatectomy specimen.
Okay,
But if you read the paper, they'll probably tell you it doesn't matter.
Dr. Moses, are you there?
Hey, Ivy?
Yeah, we lost you there for a second.
Are you there?
Kelvin?
Yeah, I'm
here. Are you there? Okay.
Okay, I was going to say I wanted to go back to the MRI ultrasound. The other platform is called Artemis. So there's two of them. One's called EuroNav, and the other one's called Artemis.
Perfect. And those are the two that are on the market for that MRI-guided biopsy.
Yeah, those are the two platforms out there for MRI ultrasound fusion biopsy.
Perfect. Very, very helpful. And we'll make sure we add that to some of our information as well. We do have a question from one gentleman who wants to know, sort of over the years, doesn't the cancer in a man's body change from an old biopsy? So I assume that he's probably had a positive biopsy, and it looks like.
Hey, Ivy, you're fading in and out, so I can't quite pick out what you're saying.
That's okay. Alice, can you hear me?
Yes. Kelvin, the question was, over the years, doesn't the cancer in a man's body change from an old biopsy? So we were talking earlier about analyzing old biopsies, but would that necessarily reflect the cancer in his body currently? Can you hear me?
Hello?
I think we're, Dr. Moses? I think we may be losing Dr. Moses.
I can hear you, but it kind of goes in and out. I hear about every 2 or 3 words.
Okay. Can you hear us now?
I don't know if it's my signal or yours. I have full strength signal on my computer.
I know. So do I. So do we. Can you hear us now?
Yeah, I can hear you. It just kind of fades in and out. Let me turn my volume down and see if that's the issue.
Okay.
Try again.
I can also. Can you hear us now? Is that better?
Yeah, I think that's better now.
Okay. I can always text you the questions as well. We did have a question about the cancer changing in a man's body from an old biopsy.
Hey, Ivy, text me the question, okay?
Okay, got it. All these forms for technology.
Okay, great. So I got the question here. Over the years, does cancer in a man's body change? Yeah, I think that's definitely can happen. The really important thing is that cancer changing rapidly or slowly. What we do know, if you go out and biopsy every 85-year-old man alive, you will almost always find some cancer. It's usually low grade. It's something that will never give that man symptoms, and it certainly won't be what causes him to die. So we know that that cancer has grown over time, likely 10, 15, maybe even 20 years, but has grown slowly. There are some men, though, that the cancer grows very rapidly over time. And so you can biopsy someone 1 year, and it's a Gleason 6, meaning a low-grade cancer. And if you wait 5 years, it might be Gleason 10. Again, up until a few years ago, it was hard for us to predict which one of those tumors would be the one that you die with at 80 years old, and which ones will become more aggressive. So that's why these genomic tests are out there. And it's hard to just say, just by looking at the biopsy, well, this will become aggressive and this will stay slow growing. But yes, over time it will change. So again, even if you decide not to get treatment, if you're a young, healthy man, I still would recommend surveillance, meaning that you're still getting PSAs periodically and you get repeat biopsies to make sure that the tumor has not grown, either gotten larger or become more aggressive as far as the Gleason score.
Great, that's helpful. Are you able, I don't know if you're able to hear us or not. I texted you a question about sort of your thoughts on Lynparza in men with a BRCA mutation.
I am not familiar with Lynparza.
It's I think it may be a PARP inhibitor. It's being used in ovarian cancer. But could you talk a little bit just about the BRCA mutation in men with prostate cancer and how that's related?
Yeah. So I'm looking at Lynparza now. So BRCA, BRCA, is a genetic mutation that has been shown to be associated with familial breast and ovarian cancers. So you see that a lot of times in younger women who have breast cancer, like in their 30s or 40s or sometimes their 20s. And if you have a family where multiple women have had either breast and or ovarian cancer, and there's been a lot of studies have shown that men in these families do have a higher risk of prostate cancer. And it's likely due to the fact that breast cancer, just like prostate cancer, just like breast cancer and ovarian, are hormonal-based cancers. And so that's why you're seeing an association. Now, I've looked up Lynparza, and it's been approved in ovarian cancer, and it looks like there is a trial they've done some phase 2 studies in prostate cancer. So they've already done sort of the toxicity studies, and now they're looking at efficacy. So there may be some promise. And so the men that would be helpful in, though, are ones that have that particular mutation. So when you're discussing a prostate cancer diagnosis with your physician, they should ask you about family history of not only prostate cancer, but any other cancers. And if there are a lot of women within your family, mothers, sisters, cousins, that have had breast or ovarian cancer, they'll probably refer you for genetic testing to a genetic counselor. And then if you are positive for BRCA, you can still get the standard treatment, but for those who, again, are concerned for aggressive disease, it looks like this medication might be an option for those men.
Thanks. That's really, really helpful. We actually, do you mind taking an advanced prostate cancer question for us?
Okay.
So the question is about after, sorry, I lost it there for a second. So this gentleman's had Zytiga, radium-223 with Lupron, and now is on Xtandi. Can you think of anything else that's available before he starts to consider chemo?
Okay, text it to me. I think I heard you, but I want to make sure I heard it correctly, okay?
Okay, Alice put it in the chat box too.
So while she's working on the text, I'll talk about those medications. So in advanced prostate cancer, so in men who have had recurrence of their PSA, a lot of times we'll use hormonal blockade or what's called androgen deprivation therapy to help control the cancer. And then also that can be used in men with metastatic prostate cancer. In a lot of those men, you can have what's called resistance to those medications after a certain period of time. And up till about 10 years ago, the only other option was chemotherapy. Now there are medications called Zytiga and Xtandi that can be used to treat men with what's called castrate-resistant prostate cancer. The question that I got, so a patient has received Zytiga. They have received radium treatment. So radium is used to treat men who have symptomatic bone metastases. And it sounds like they're now on Xtandi. So
yep.
The two medications that are out there are Zytiga and Xtandi. There are trials at looking at using both, so men who have failed one, meaning that they have progressed on one medication and then progressed on the other, can they use both at the same time? That's under the guise of a clinical trial, so I don't know of a lot of physicians who are doing that. You do need to stay on your hormone shots that you were getting before. So most men are on Lupron or Firmagon. Once you have failed both of those medications, the next step is chemotherapy. And the most common one that we start with is something called docetaxel. The one thing that you do want to know is how much metastatic disease. So for this particular patient, he's gotten Zytiga, he's gotten radium, gotten Xtandi. If he has a low metastatic burden, meaning not a lot of tumor in other areas, particularly if it's just in the bones, you can try Provenge, which is called Sipuleucel T. This is an immunotherapy where they take leukocytes from your blood, white cells, they culture them with a specifically tagged protein that has been attached to an antigen within the blood specific for prostate cancer, and then it is reinfused back into the patient as an immune therapy against prostate cancer. So if this patient has sort of a low metastatic burden and does not have a lot of what are called visceral metastases, meaning spread to the liver or the lungs or the brain or something like that, Provenge may be an option. If they have a high metastatic burden and they've been through all of these medications, then according to the guidelines, docetaxel is the next step.
Great, thank you very much. I think that's very helpful, and I appreciate you sort of covering the whole spectrum there. I think I just sent you our last question about what would be the recommended test for the gentleman who has a PSA of 4.23, a Gleason 6, and a T2A. So, and he's also thinking.
You know, and this guy, this is a young man. PSA is low, Gleason is low, so I think Oncotype and Prolaris are both excellent ones. There are other tests called the 4K, which is a good one. We didn't talk about that on this particular seminar, but that is another test that can be used to determine aggressiveness of disease. Again, in my practice, I'm a little bit more familiar with Oncotype. But in someone with this type of features, I think Oncotype and Prolaris would both be reasonable, particularly if he's trying to decide on active surveillance. Another option also is to get an MRI to make sure that the biopsy did not miss any lesions, or make sure that there were not any lesions missed on the biopsy. Sometimes there are tumors that are deeper within the prostate that we don't typically get on a standard biopsy. And so MRI could also be used, not necessarily for a fusion biopsy, but just an MRI just for visualization of the prostate.
Great. No, that's super, super helpful. And with that was our last question. I just want to thank you. Thank you, Dr. Moses, for taking the time this evening from your meeting and your schedule to join with us. I think this is probably the best Q&A session we've ever had. I appreciate it. The program will be available on our site. Some folks have asked to have the slides forwarded, so we are happy to do that. If you have additional questions and you'd like us to be in touch with Dr. Moses, I'm happy to email them to myself or to my colleague Alice Lee. And with that, I just want to thank everybody again for their enthusiasm and for the great presentation. Again, for those of you online, please feel free to do the survey afterwards. And I want to thank our funder for this program, Genomic Health. It was really helpful to be able to bring this to you. We're glad to be able to do it at the end of the year. And just a quick plug, check back on our site. On the 15th, we'll be doing a webinar about getting through the holidays with prostate cancer. And so with that, we wish everybody a happy, healthy holiday. And thank you again for joining us. And again, Dr. Moses, thank you so much for sharing your expertise with us this evening.
Thank you. Thank you for having me. Really appreciate it.
Oh, this is really wonderful. Thank you so much. Have a good night.
Okay,
Bye-bye.
good night.
Good night.